hear me. So welcome to this Clinical London presentation, and I'm sorry there's been a little delay to starting. This will be an interactive seminar, so if you have any questions, please do put them in the Q&A section. I will be monitoring that throughout the presentation, so we'll have pauses to answer any questions that come up. So please do put them freely in the Q&A. So without further ado, I'm going to introduce Naomi Tan, who is a consultant who's joined Clinical London recently. She is a specialist in pediatrics. She is a specialist in squint, and she's going to talk to us today about red eyes in children, which I think is a very common problem and that we all want to know very much about. So Naomi, you are free to take it away.
Thank you very much, Jen. Can I just double check you can hear me and you can see my slides?
Somebody put a little comment in the Q&A and chat to confirm that, please. I can see everything fine, Naomi.
Thank
Excellent.
you. Okay, good evening, everyone. Thank you for joining on this cold, dark night. So without further ado, so just a little introduction to me. Thanks, Jen, for introducing me. I am a consultant ophthalmologist, and my NHS work is at the Royal Free London NHS Trust, and that covers Edgware, Chase Farm, and the Royal Free. And my special interests are in paediatric ophthalmology as well as adult cataract. I'm the Deputy Clinical Lead for Ophthalmology at the Royal Free. I'm also a personal tutor to University College London medical students. And I work also at Clinical London in my private practice. A little summary of my CV: I've had two-year fellowship in paediatric ophthalmology at Moorfields Eye Hospital. I did my specialist training in North London, and I've worked at Moorfields as a locum consultant in the eye casualty. So I was asked to do a webinar, and I thought that this might be an interesting topic for you: red eyes in children. But you know, it's a potentially vast subject. I had a little look, and this nice paper from the British Journal of General Practice lists common presentations of red eyes in children. And I've put on the left there, you know, presentations that you may actually see more than I do. These are self-limiting conditions that may well be, you may well be dealing with in the community. And I thought that perhaps you might, you know, you might be very experienced with this. And so what we'd like to do this evening is be a little bit interactive, and just to sort of check who's really out there, and try a little bit of technology. Bear with us as we see if it works. Excuse me, wrong way. We're going to do a little poll just to see if I was right about that. So let me just see. So you hopefully are seeing on your screen, have you treated any of those conditions in the community if you're a community practitioner? I'm talking about any age of patient. Have you done it without the help of an ophthalmologist? I'll just give you a few moments to press the buttons. Wow, you're all fast. Okay, I think most people have answered. And I am seeing that 94% of you have dealt with these conditions in the community without the help of me or Jen. And so yeah, so I'm glad I was hopefully right about that. Now, just further query from me is: have you treated these conditions in a child comfortably without the help of an ophthalmologist? So let's just launch that poll. Yeah, you've all got fast fingers. So we're going to end the poll slightly less, 10% less. 83% of you have been dealing with those conditions in the community in children without me. So I'm glad that my supposition was correct, and hopefully you've read a little bit in the blurb and weren't expecting to hear all about those things today. So what we're going to do this evening is narrow down the scope to where I hope it might be a bit more useful for you. It might enter into an area that you feel less comfortable with, a little bit more unsure, and we're going to talk about chronic red eyes in children. So those conditions on the list previously, within a couple of weeks, might settle with your guidance, community-based treatment, things that you can get from the chemist. But for the children that have a red eye that sort of doesn't go away, they're just sort of, it's indolent, as in it's chronically not great. You know, they've just got a little bit of a red eye, they've got sensitive eyes all the time, and they may run into acute exacerbations where one or both eyes gets worse, you know, maybe for not any particularly good reason. And you may be worried looking after these children of, is there a potential here for vision loss in the longer term? And so we're going to look at a couple of conditions that largely affect pediatric populations and do, you know, fit all of these criteria. And they are the, you know, we love an acronym, BKC and VKC. So blepharokeratoconjunctivitis, and I'm sure you know that means inflammation of the eyelid, cornea and conjunctiva, and vernal keratoconjunctivitis, which vernal means spring, which is a bit of a misnomer, and we'll talk about that, and keratoconjunctivitis, inflammation of the conjunctiva and cornea. So the learning goals for this evening. I hope after an hour of this, you're going to have some understanding of the potential long-term implications of uncontrolled chronic ocular surface inflammation in children. And we're going to talk a little bit about the presentations of BKC and VKC, and look a little bit about when you can treat in the community and when you might want to be involving secondary care. These are diseases that cover a spectrum, and not all of it needs to come to hospital. So they both have a treatment ladder approach, and we're going to talk through that. And then we'll finish off with some advice about how to examine a child with red eyes and look at some of the red flag signs. And by that, I mean signs that really want to make you sit up and take some action quite urgently. So my declaration is I work at Clinical London. That's really my main declaration. I don't have any interest financially in any of the treatments we're going to talk about. So a note on patient images. So as we go through the talk, you're going to see lots of pictures, and some of them are taken from the literature and cited. Others, some patients have very kindly agreed to include in an unidentifiable way their images, and I am very grateful to them for that. So do let me know if there's any questions as you're going through, but I'll let Jen interrupt us if there are. And we'll start with vernal keratoconjunctivitis, VKC. So this is a chronic condition. We can't completely cure it. We can't make it go away. And the goal of managing VKC is about improving the symptoms, reducing the long-term complications, and balancing that with any risks of treatments we're giving a child. So it is a relationship that goes on during the duration of their disease. The child may experience itching, light sensitivity, watering, mucus discharge, a foreign body sensation, or pain. But I would say, much like this patient, commonly they're not complainers. They may not be complaining of anything, but they may look uncomfortable. They may look like their eyelids are drooping a little bit, their eyes are not fully white. And here is a picture of a child having a flare-up of VKC. Now, the child who described the symptoms to us did notice an exacerbation in spring, as is classic of vernal keratoconjunctivitis, but that's not necessarily the case. And some children go on to develop chronic symptoms year round that don't particularly have a worsening in spring. So that's just something to be aware of. Generally, the children will have a history of atopy. So that's allergy or hypersensitivity, and that may be in the form of eczema, asthma, hay fever type hypersensitivity. This condition classically affects males more than females, and they're about 3 times more likely to be a boy. But of course, this is just statistics. It can affect anyone. And it's more common in South Asian and Middle Eastern children. It can present from age 5 onwards. And, those can be difficult children to examine when they're quite little. And the great thing about VKC is in a lot of children, we can expect it to resolve by puberty. So we are really trying to get them through the worst of it without long-term complications, and maximizing their enjoyment of life in the meantime. So it's really important to understand that it's a spectrum of disease. So we're going to look at the signs that you might see in vernal keratoconjunctivitis. And some children will have mostly the limbal signs around where the cornea meets the conjunctiva. Some will have more tarsal signs, so in the conjunctiva as it reflects under the inside of the upper lid, and others get a mixed form. Some children will get one episode and then it will settle down or be managed with very little treatment, and others will keep breaking through the barriers as we add more and more preventative treatment. Their disease may flare up through it. So we need to keep working with those children to get their disease into a controlled place. So clinical signs in VKC. So here, to orientate you, you're looking at an everted upper lid. So I'm sure you're all very familiar with that. And what you can see here are giant GPC, giant papillary conjunctivitis. And it's sometimes described like a cobblestone road. It looks like a lot of cobblestones. And you can see that in between those cobblestones, you've got sort of mucus collecting, and some areas aren't so cobblestoney. Sometimes that means that they're not affected. Other times that means they've gone beyond inflammation and into fibrosis. So they've lost that cobblestone appearance, but are scarred effectively. And what are these? Well, as a sort of reaction to something, there has been conjunctival epithelial hyperplasia, and inflammation recruits in lots of cells. There are eosinophils in these papillae, and lymphocytes and fibroblasts, and there are proliferative changes which remodel the shape of the conjunctiva inside the lid to create these big lumpy papillae. So it's really important to be everting upper lids, as again I'm sure you know, because sometimes the sign and the cause of a child's discomfort can be hidden if you don't avert the lid. The limbal form of the disease can cause hyperemia of the conjunctiva, an injected, uncomfortable look. And if you look at the superior cornea here, you don't see that nice clear line of where the cornea is meeting the conjunctiva. There is this sort of gelatinous blob looking, effect, and that is inflammation of the limbus. Again, it's papillary, it's infiltrative. The conjunctiva has been remodeled there by inflammation, and that can be really uncomfortable. Horner-Trantas dots, again, is similar mechanism of action, but here you're looking at these white collections, that little spots at the limbus, which are called Horner-Trantas dots after, I think, Mr. Horner and Dr. Trantas. And they are another sort of pathognomic sign of vernal keratoconjunctivitis. And then in the longer term, so those previous pictures show a kind of, really active disease, limbal inflammation there was what I would call a flare-up. But in the longer term, you can get some more chronic signs. This picture shows pseudogerontoxin, which is these white areas in circumferential in the peripheral cornea, which look a bit like corneal arcus or arcus senilis. And they're not because the patient's old or because the patient has high cholesterol, but this is a kind of chronic scarring in the anterior corneal stroma related to having had chronic inflammation of the limbus previously. So if you look, you may see that in some patients. It's not a sign of active disease, but it can be seen ongoing into the child's future. And this is an anterior segment OCT showing the cornea across the top here to orientate you. That's the angle, the iris, the lens. And these white bits here are those pseudogerontoxins. So it's in the anterior part of the cornea. So what are the red flag signs in VKC? Well, if a child is presented to you with those previous signs, it's really important to look at them in the context of the history. Has the patient suddenly become really uncomfortable in the last few days? And is this an acute exacerbation? Or has the child been grumblingly not quite right for weeks and months? That can really help you understand the urgency with which these children need to be seen. And they do need to be seen. If their eyes look like that, they absolutely, they need steroids effectively. But how quickly? So, you're going to send them straight off, or are you going to try and get them into the next available pediatric ophthalmology clinic, which is a good setting for them to be seen in? You really have to be guided by that history, because if you can get them into a pediatric clinic, then that's good. It's a less stressful environment than an eye casualty. But if they are acutely deteriorating, there are always eye casualties. But the sign to look out for me in VKC, that is a red flag that means you should be acting now and in the next 24 hours, is this. So you'll be, to orientate you on this blue picture, and I think if you're optometrists and eye healthcare professionals, you'll know that blue light, you're looking at a cornea with fluorescein on it. So now, if you reflect on where you mostly see fluorescein staining, it's usually in the inferior part of the cornea. It's not uncommon in adults, associated with blepharitis, and it usually is it's not too terrible a sign. But if you think about it, you actually very rarely see the superior part of the cornea with lots of punctate staining. And so I would just like you to sort of bank the thought that if you're seeing a child with this sort of history, chronic inflammation in the eyes, itchy, really uncomfortable, and you see this, then I would like you to think, I'm quite worried about that. And the reason to worry about it, so I've drawn it diagrammatically here. So these little punctate stains, they can actually go on to sort of coalesce into one big epithelial defect. So if you see it where it looks like that picture and there's a lot of staining all in one area, it is on the path to breaking down entirely. And that is called a shield ulcer. So in the setting of chronic inflammation on the surface of the eye, there are lots of inflammatory mediators all the time. Those mediators can be toxic to the endothelium directly, the epithelium of the cornea directly, but also in the context of finding lots of big cobblestone papillae under the lid. Think about what that is doing mechanically. Just every time that child blinks, they are rubbing these big papillae, big cobblestones over that area of the cornea, and it can break down and form a shield ulcer. And so it's an emergency. You want to be trying to reverse that process with steroids really promptly, because you hopefully could get it to reverse before the ulcer occurs. And a shield ulcer is not nice. It's really uncomfortable for the child, and it can be really tricky to treat. So the epithelium breaks down, Bowman's membrane is exposed. It tends to kind of gather mucus that kind of forms a plaque over the epithelium, and that makes it harder for the epithelium to heal. While the epithelium's broken down, that cornea is at risk of infection over the top. So they could get a corneal ulcer associated with this, and it's all not good news. So if we can avoid it getting there, then we absolutely should. And a lot of the management of the chronic management of VKC is trying to avoid ever getting to this place. All the treatment should be trying to reduce the load of inflammatory cytokines on the surface of the eye, just avoid this situation building up. So why is it a problem to have chronic ocular surface inflammation? If that child's not that bothered, they're okay, they're getting on with it. Well, the problem is that chronic inflammation leads to scarring. So inflammation is a healing mechanism in the body. So if you cut yourself on the hand, you get inflammation occurring. It'll swell up a bit, that opposes the edges, you get all these cells coming in, and they heal with a scar. And in that scenario, scarring is really good. But what I tell my patients is the whole job of the cornea in its life, very simplified, is to be see-through. We want it to stay see-through. And the problem with scarring on the cornea is it's not see-through. It can be opaque. So if you look at this picture on the bottom right of your screen, that's showing a scar after a shield ulcer, which you can see has rendered that nice clear cornea opaque. And clearly there is a risk of vision loss associated with that. So the treatment when we see VKC presenting is to try and calm that inflammation down enough that we don't end up in that place. Another problem with chronic ocular surface inflammation is there's loads of eye rubbing. And we know that there is actually good evidence that mechanical rubbing of your eyes, lots and lots, can put you at risk of keratoconus longer term. So we are really conscious looking after these children of checking their vision, checking their refraction on on an interval basis to look for any signs of that, but also trying to keep the inflammation calm enough that they're not wanting to rub their eyes all the time. So treatment of VKC. Now, I'm not going to go into absolutely loads of detail about it, but what I want you to take away is that there is a sort of treatment ladder approach, some of which can be started and managed in the community. So the first thing to consider is the environment. If there is an obvious allergic stimulus for that child, then it's something that you could consider trying to modulate. It's not something we dwell on a lot in pediatric ophthalmology, because commonly the allergen might be something that you can't avoid. House dust mite, tree pollen, grass pollen, things that you can't just avoid. And the goal here is to let children live their lives. You don't want them to be avoiding things a lot. So the first line treatment is antihistamines. So if you see a child with itchy eyes, it's really uncomfortable, some over-the-counter antihistamine drops is a really good place to start. And for some children, that will be enough to just calm down the process. But for those that have the antihistamines and that they don't help enough, we'd reach for steroids. And in those pictures of the really red eyes, big limbitis, huge papillae, those situations do require steroid to calm down. But we'd use that in a stepwise manner. So the child would have antihistamine drops, and I like to use olopatadine. It's got 2 mechanisms of action. It's used twice a day compared to something like sodium chromoglycate, which is 4 times a day. And what I want you to take away here is that we could potentially be starting to ask these families to put in multiple drops per day into their children's eyes. And I am very sensible to the impact that has on families. And I do hear, you know, anytime I say more than 3 times a day, we're talking about potentially introducing a drop that has to go in at school. Sometimes parents are going in to put the drop in school, or the child is coming out of school to the school nurse. And so ideally, we want to just keep the medication to the minimum, but keep the control good as well. So it is a bit of a balancing act. Now, steroids can be given topically, and that's usually the first line, eye drops with steroids of different potency. But where there are huge papillae, we can give subtarsal boluses of steroid injected. And in most children, that would require a general anaesthetic, but it is an option, particularly where a shield ulcer is possible. And you know, in the worst of cases, it's possible to even consider oral steroids. But the systemic steroids obviously are going to have much more systemic side effect. I think Jen's got a hand up.
Yes, I'm just going to interrupt for a couple of questions coming in. We'd better take them as they come.
Yeah.
So the first one is, could you use ketotifen instead?
You can, yeah, absolutely. There are different anti-histamine drops, and often it varies depending on what's available, and on formulary where you're practicing. Ketotifen is a good option. Even the ones available in pharmacies, you know, sodium chromoglycate, it has one form of action. It's a mast cell stabilizer. Others have multiple ways of acting. So yeah, absolutely, antihistamines of any sort are usually a good thing.
Perfect. And then the next one is also about drugs. So with olopatadine, would you use for 4 months and then 1 month break before restarting?
Yeah, it's tricky, because I think the published evidence is that it works for 3 months, and then the effect might cease. Now that's really difficult, because as you look down this treatment ladder, we are looking to every step increases the risk and the potential unwanted effects of the treatment. And for me, olopatadine is a really safe drug. There's essentially no side effects, and it doesn't just stop working at a certain point. In my experience, it's worth continuing it. So the month break isn't necessarily required. Yeah.
Okay. Perfect.
I do use it for longer.
Perfect. And then the next 2 questions are sort of linked in a way. Which steroid, FML or DEX, and would FML be strong enough as a first course?
Yeah, so that's a good question. And the part of the reason I was vague in this treatment ladder is there is quite a lot of nuance to how to treat, and it depends on the presentation. So always you're balancing risk of the disease itself and the degree of risk to the eye, to the vision, of scarring, the degree of discomfort the child is in, versus the potential side effects of the steroid. And so the person asking the question there is asking whether FML, which is fluorometholone, which is a less potent topical steroid, and which tends to penetrate less deeply into the eye. You don't need it to penetrate deeply into the eye for ocular surface disease, but it's less potent than something like dexamethasone. And for a big flare-up, I do reach for dexamethasone with caution in children, because various things. You don't want to be giving lots of drops that aren't enough. So you don't want to ask a child to put in 6 times a day FML when they could put in 4 times a day Dex, because of the impact on their life. With any steroid, you want to see it really quelling that inflammation within the first few days. That's the goal. We then taper everything to get down to nothing. But I would rather go in strong to start with, get things under control, and then gently taper and consider switching to a less potent steroid. then going in too mild, not suppressing the inflammation, there still are some risks with any steroid. And what you don't want to do is just not give enough, the inflammation get a bit better, and then as you try to get rid of it, all the inflammation just comes back again. So it's better to, if you can, go in firmly to try and get on top of it. There are still cases that, you know, even dexamethasone is not enough, and you can see that on the treatment ladder here. So yeah, just to mention there, what we're worried about with topical steroids is the side effects on the eye, which are high pressure steroid-induced glaucoma, which is a real possibility. So I would never discharge a child on steroids. I always monitor their intraocular pressure. And cataract in the longer term, you know, it doesn't form overnight, but these children do have a chronic disease. Over time, they can have had enough steroid to give them a premature cataract. So we really want to minimize how much is being given, but give enough for it to be effective. And it's important to look at the bigger picture. So where a child has required 2 or 3 courses of steroid in the space of a year, I begin to look to steroid sparing immune suppression, because they're having recurrent flare-ups, they're requiring lots of steroids, and we don't want to, you know, we want to avoid lots of steroids if possible. So things like cyclosporin and tacrolimus, they are calcineurin inhibitors. They work in a similar way to steroids, but not as fast. So they take longer to build up, and they do not have those side effects of cataract and glaucoma. So they are, ideally, I would like to get children who have multiple flare-ups steady on some baseline treatment of antihistamine and a calcineurin inhibitor to reduce the frequency of flare-ups and reduce the, you know, the severity of a flare-up. But there are children who still break through, so it can be challenging to manage.
Okay, no, so we've got a few more questions coming in. It looks like a very hot topic, and certainly, actually, they're answering some of my queries as well. How quickly can a shield ulcer develop if you consider it do you consider it an emergency?
I do. I mean, if you are seeing those near confluent punctate stains, you, especially if the history is that the child has become really uncomfortable in the last day, it can be that fast. And what you really want to do is get in there with the steroids as soon as possible. And, you know, again, as I say, the presentation will often tell you how urgent it is. But I do see these children, you know, presenting with a shield ulcer like this. They've been to school, they've been all day, but they just won't open one eye. And that's a bad sign. So, you know, even if they're not complaining, got to worry about it. So, yeah, I mean, I wouldn't send them at 3 o'clock in the morning, but you're probably not seeing them at 3 o'clock in the morning. But I would start treating it if they walked in at 3 o'clock in the morning into a casualty.
Okay.
But promptly.
And do steroids improve the appearance of papillae, or do they just improve the symptoms?
Both, yeah. And actually, sometimes you can get a really dramatic improvement with a subtarsal bolus of steroid. They can just sort of melt down, which is what you want them to do. Yeah.
Okay, perfect. So I think we've got 2 more questions active. We'll answer those, and then we'll let you get on with your presentation, and then we'll take some more a bit later. So firstly, would you taper the steroid at a similar pace for a child as you would an adult?
Yeah, again, that's quite depends on the circumstance. But yes, yeah, I mean, a course of steroids is often 4 weeks, sometimes longer if we've seen them rebound after the reduction of steroids. We might go slower, again, with caution, checking the pressure, making sure they're okay, considering switching to a milder steroid as they get down. But yeah.
Okay, and last one is how does tacrolimus help a VKC flare-up? Would it penetrate through the lid?
I'm not sure if that's asking about the how it's given or how it helps. So tacrolimus and cyclosporin sort of stabilize the whole situation in the first place. It doesn't mean to say you won't get you won't get a flare-up. But the hope is that you will get less of an intense flare-up. I think what you may be asking, though, it's a skin ointment, and how is it going to get into the eye? Well, actually, cyclosporin has a license for use in children, so we always start with that. But where it's not working, tacrolimus ointment for the skin preparation, there is published evidence of it being used in the eye in this situation. So it is off license where we use it, and I would obviously counsel parents of that, but you actually put it in the eye, so it doesn't have to get through the lid.
Okay, one more, which I think should be a quick one. If GPC is present and causing corneal staining, could we consider a bandage contact lens while they await ophthalmology appointment?
Yeah, I mean, that's an interesting one. I think if you're seeing corneal staining and big papillae, particularly those superior ones, yes, in theory it's a good idea, but I think it's better to be getting on and dealing with the problem, because some of that epithelial problem will be coming from a mechanical rubbing, but some of it will be coming from the fact that the whole situation is just very inflamed, and there's lots of kind of inflammatory cells toxic to the epithelium there as well. So a contact lens won't help that second part. And obviously where epithelium is breaking down and there's a risk of infection, and introducing a contact lens, and also particularly if this is a 5-year-old, you might not be able to get a contact lens in. So it's better just to get on and start treating them, I would say. Right, shall I march on? So I think I've got to get my skates on. So just to say, some of that can be happening in, above the line, could be happening in the community, and some children will just be better just with those first lines, but not all. So I think I've talked about this, what are we trying to do? We're trying to get them into a comfortable life, that they're not limited, they're not avoiding things. Support the parents. Parents become really expert at this. There is no minimizing that this impacts on families. They're putting those drops in. They've got their apps set to remind them to put drops in. And it does affect family life. So I do make sure that people can contact us. They know when they're having a flare-up, and I like to try and be available to get the child in when they need it. All right, so I was going to make you do some in case you were dozing off out there. So let me see. We've got question 4. You know what? That's okay. Answer that question. It's not the one on your screen. Which of the following is the possible unwanted effect of steroids? Brilliant. You're all listening. Thank you very much. Yeah, absolutely. Glaucoma. It's not myopia. It's not iritis. So we're going to... Apologies. So which is a red flag sign in VKC? That's it. Yeah, I can see people thinking and possibly changing their minds, but most of you are absolutely right. Superior punctate staining, but all of those are signs of VKC. So we've done that one and we've done that one. So this must be the previous one. Oh, I do apologize. I've gone a little bit awry with the questioning. I'm not sure I can launch that question, but when might you commonly expect VKC to resolve? By 10 years, at puberty, early 20s, continues to adulthood. So the answer that we hope is going to happen for most children is at puberty, that they will just grow out of it. So we've just got to get them through till then. Okay, so no talk on children's eyes would be complete without amblyopia written in big capital letters. So it's so important to, when we're getting caught up managing the ocular surface, to remember the child as a whole. And this does affect children from 5 years onwards. If they are getting a lot of ocular surface disease, if they're getting scarring, we must remember amblyopia, so that it's really important that these children are having regular age-appropriate formal vision tests, refraction, and then that we consider amblyopia treatment if it's necessary. And so there is a poll here. Oh, but I think I sort of slightly launched it. I do apologize. So amblyopia in ocular surface disease may be caused by which? Induced astigmatism, ptosis, corneal scarring, or all of the above. it's all of the above. So if they get scars, if there's big papilla making their lid hang over the visual axis, if they've got scarring that's giving them an astigmatism in one eye asymmetrically, we've always got to be thinking about amblyopia. Okay, so we've talked for absolutely ages about VKC, but let's give some time to BKC, and I will try not to linger too long and keep you any later. So BKC in children. So you'll all be really familiar with blepharitis, I'm sure. And the point of the take home here is that BKC needs to be thought about as a slightly different entity in children. And the reason is that their children are more likely to get a corneal complication from blepharoconjunctivitis than adults are. So just bank that. Excessive blinking, red eyes, burning, foreign body sensation, photophobia, recurrent chalasia, conjunctivitis, inflamed eyelids. So again, that kind of chronic red eyes are not quite comfortable. And looking at the ages, from 6 months onwards, we can see children with this up into adolescence, commonly age 4 to 5, mean age of diagnosis 9. And my impression of this is that often children may have been grumbling along for a really long time before they get into the clinic. So there might be quite a sort of, not a delay to diagnosis, but a slowness in recognizing that there's an issue. And again, South Asian and Middle Eastern children are a bit more at risk. So you'll all be familiar with anterior and posterior blepharitis. And you see here this crusty stuff on the lash follicles at the base of the lashes in anterior blepharitis, and posterior blepharitis, the meibomian glands are plugged. That oil forms its own little plug and stops the nice oily goodness getting out onto the eye surface and can plug up and form chalasia. So in the sort of spectrum of blepharitis, you can get meibomian gland dysfunction, reduced tear breakup time, dry eye type feelings, chalasia that keep coming or in different places, that chronic red eye, children get flictons, but they can also start to get infiltrates and vascularization of their cornea. That can cause scarring. Scarring can cause induced cylinder. Bad inflammation can cause corneal perforation. All of this can have superadded amblyopia, and we mustn't forget the side effects of treatment itself, secondary glaucoma and cataract. And you know, nobody is completely clear on what is happening, but it's felt that staphylococcal bugs are living in the blepharitis on the lid margins, and there may be a direct exotoxin coming from them, but also a hypersensitivity reaction. So that sort of overreaction from our own immune system causing some of that inflammation. And the children can be more susceptible to corneal damage. The incidence of complications is greater in children. So let's just bear that in mind. And you'll all have seen children like this who get recurrent uncomfortable chalasia, which is not nice and can be treated, usually with topical or oral macrolide antibiotics. But here again, no matter what age this child is, I would be wanting to get a nice look at the cornea to make sure underneath that there isn't sort of gradual vascularization occurring from chronic inflammation on the ocular surface. And sometimes you can be surprised when you put some fluorescein in. The eye may be that sort of just not very white, but not very red either. And you can sometimes find that there is really marked punctate staining, causing the child to have that sort of chronically uncomfortable eye. Flicton. People often get really worried about these because, you know, they do cause a lump to grow on the surface of the eye. And again, that is an inflammatory sort of mass, commonly in very little ones, toddlers. And that's similar staphylococcal hypersensitivity reaction. And again, you'd want to get a nice look at the cornea. And the punctate staining in blepharitis, as you know, is more commonly inferior. You know, if you see a child like this, initiate those really sensible first-line treatments that you do in adults warm compresses. They could try lubricant drops if they're able to tolerate them, but warm compresses for a good 4 or 5 minutes, so really melting those oil glands, can help here. But if you're seeing that, you know, that degree of staining, you may want to routinely refer them in for some management, because what can happen is with chronic staining and punctate breakdown of the epithelium in children is that you can get corneal vascularization. You see those little blood vessels growing in. That can sometimes lead to a marginal keratitis, where all those inflammatory mediators coming out of those blood vessels cause often sterile infiltrate in the cornea. And there you might be getting more of an acute condition of a newly uncomfortable eye as the epithelium breaks down. So that may heal, but where the scar has been, you may get further ingress of vessels, and that might mean that the next time that marginal ulcer is not so marginal, it's a bit further in and closer to the visual axis. So really, this is a process that you want to be controlling before it runs uncontrolled into causing problems with the vision. So again, reduced vision from corneal opacities, irregular astigmatism, amblyopia is always on our minds. Jen.
Hi, Naomi. We have a few more questions coming in. We should have a little break for engagement. So one is going back to VKC, and someone's just asking what percentage of VKC patients would go on to develop AKC.
It's a good question. I don't think we know the actual number, but I think it's a minority. And in my mind, it's sort of the order of 20% might go on to have a chronic atopic situation on the ocular surface, and a lot of the children will grow out of it. So there is that hope for those families.
Great. And they wanted you to just repeat what type of antibiotics you would use on chalazion?
Yeah, absolutely. So I think we might be, got another ladder for you. Do you want me to do that now, or? Yes,
why not? Why don't you do it? And we'll do the other couple of questions a bit later.
Great. So yeah, treatment of BKC, blepharitis, hot compresses, they're really good. And I do tend to, anything that stays hot, a hot water bottle with supervision. I don't tend to recommend a hot flannel, because hot flannels don't stay hot long enough. They need to stay hot for a good 4 or 5 minutes. And the little microwavable eye masks or the various other things that are available are quite good because they perform that exact function. So doing that with a gentle massage can get the oil glands moving. Antibiotics. So there are a couple of main choices. Macrolide antibiotics. We don't use doxycycline in children. Doxycycline is given commonly in adults for the anti-inflammatory and antibiotic properties, but can cause real staining on children's teeth that is permanent. So we just don't do that. A good option in children is erythromycin, macrolide antibiotic. It's given about half the dose that you would give for a chest infection, for example, but over a longer period of time. And that's because we're not really giving it for antibiotics' sake. These antibiotics have really good anti-inflammatory properties on the eyelids. And the main side effect of doing that is a tummy ache. So I usually say give it with food, and we stop it if it's not tolerated. But more recently, we have azithromycin eye drops, and that's probably my first go-to if giving drops isn't a real issue for the child. And the published regimes vary, but they don't have to be every day. They've got a good half-life on the eye. Do a prolonged course for several weeks of azithromycin drops, and they can be really effective in getting those multiple chalazion to settle down. What you don't want to be doing is operating on every single chalazion as it comes up. You need to be sort of going to the root cause of the problem. There definitely is a role for steroids, again, sparingly, bearing in mind the potential side effects, and that's where for flare-ups, epithelial breakdown, lots of punctate staining. And some children do need immune modulation, and we certainly would be thinking about that for children who've had a big keratitis episode associated with BKC. We really don't want any more scarring to be happening in those children. You know, in the rare and awful, you know, rare occasion, keratitis can go on to perforate the cornea and require corneal grafting, but that is very uncommon, thankfully. Yeah, you catch my drift there. I won't go on about it. Yeah, little poll for you. I think this could be our last one. Oh, okay, just get that launched. Oh, I'm so sorry. Where I have previously accidentally launched these, it's not letting me redo them. So just in your mind, what are children more at risk of in BKC than adults are? And they get all of those things, but the corneal damage is just a bit more likely to happen to a child. So you've just got to be really wary of that.
Okay.
Okay, we're home straight and we've got 5 minutes.
Just before
so Jen,
you
if you
launch
want
in
to
the home
moderate the time.
straight, just before you launch in the home straight, Naomi, I think we'll put a few more questions through because I know you'll get a flood at the end as well.
Right. Okay.
So first of all, with that level of SBK, so the one you were showing a few slides ago, what would you expect the patient to have? I think they're asking in terms of symptoms, and also what level of SBK would the refraction be incorrect? So with what level of SBK would that affect the refraction?
Yeah, good questions. So at what point would it affect the refraction? So taking that one first, I mean, it would probably affect your ret reflex quite early on. You know, if you were retting that child, you'd think, oh, it's not quite right about this, and you'd look at the slit lamp and find all of that. And a child comes to mind who had that, and again, not very red eyes, really, chronically not comfortable eyes, but pretty white looking, nothing really to worry about. But actually, at the slit lamp, she had loads of punctate staining, and her vision was down to 0.3, so 6/12 in that eye on the first day she presented, compared to 6/6 in the other eye. And I was really worried that, gosh, has she managed to get amblyopia from just punctate staining? But I think she was just really uncomfortable / blurry on that day of testing, and after a course of treatment that was gone and her vision was much better, so she didn't need any amblyopia therapy. But it can have an effect. I have a feeling I've answered only half that question.
I think the other half was about what symptoms would with that level of SBK, what would you expect the patient to have? I think they're asking in terms of symptoms.
Yeah, in terms of symptoms, again, I do get the impression children get really used to this level of ocular surface discomfort, so their symptoms can be really quite misleading because they can seem all right and not complaining, and it may be like that first patient, they're just not telling me that they're not all right, or that they're just so used to it that they've stopped noticing. They're just tolerating a level of discomfort. So I don't always gauge based on the symptoms, because I look at it and see, I know I would be deeply uncomfortable with a lot of punctate staining like that. You know, as with adults, you know, a tiny little bit, a few bits of staining, okay, but if you're getting a big diffuse area, it will be uncomfortable.
Okay. And as a community optometrist, if they see a child with a chalazion or stye that doesn't resolve with warm compresses and lid massage, should they consider referral to ophthalmology, and after how long from the outset?
Yeah, that's a really good question, and I'd say they can be quite liberal. Early hot compresses, fairly generous massage. You know, we don't want to be squeezing it, but you often, particularly if you ever see a point coming to it, you can often massage them out. But some of them do kind of sit around and not go away. It's the things to consider are that to do anything surgical with a chalazion in a child requires a general anaesthetic. So where with an adult you might lie them down on the couch in clinic and do it with their consent, you cannot do that in a child. If you've got multiple chalasia happening, it's a good idea to introduce the antibiotics early. But if it's just the one, it's really worth persisting with those warm compresses, because the natural history of a chalazion is it will go away. They're not going to be 25 and still have it. And you know, when they come to see us, we will be balancing the risks of general anesthesia for a chalazion it's not impossible. And if they're big, sometimes they get enormous, they get ptosis with it, they can't see past it, then that has to go actually in a child of amblyogenic age. That would be a priority for the vision. So we consider all of those things. So it's not a rush. They should do the warm compresses, don't give up. It can stop them getting another one if they're doing them. But you know, if in doubt, send them in and we can have that conversation with them. But they will usually resolve on their own if you're happy with the ocular surface otherwise.
Okay, that's great, Naomi. I think we'll let you finish your talk and then we'll address all the others at the end. And any people who need to go early, they can run off at that point.
Lovely. So yeah, this is the finish with a big bang. Examining a child with red eyes, and this is where you are going to hope I'm going to give you a magic wand that's going to make it easier. So I'm sorry to disappoint. There's no magic wand for examining children with uncomfortable eyes. But what I can give you is a pediatric ophthalmologist's top tips. So number one, empathy. Try and put yourself in that child's shoes, especially if they've got a chronic uncomfortable eye. They're managing it. You're a stranger. They don't want you to anywhere near them, and that is very reasonable. So it's good to be trying to be empathic with, you know, the fact that they don't want to get through that your rushed consultation. It's time to slow down, especially if you are suspecting some more serious pathology. You need their trust to get near enough to them to get the things that you need, get the assessment that you need to help them. And rushing these children is not the way if they are reluctant. So how can you do it? My top tip, don't ever lie to a child. If you find yourself trying to put in cyclopentolate drops and saying, it's just like water, just don't, because it's not just like water. It really stings. And children are not stupid, and they do remember like elephants. You know, if you tell them that, you tell them a fib once, they're never going to believe anything you say ever again. So just don't do it. And, you know, what I do tend to say is, I don't lie to children. These drops are a bit stingy. I think they're really important. We're going to put them in and I want you to close your eyes and we're going to count to 10 and they're going to stop stinging. Something like that, but tell them the truth. That's really important. But you can make the truth more interesting and more fun than you would to an adult. So to you and I, that's fluorescein staining to look for very serious ocular pathology. But in my clinic, those are glow-in-the-dark eye drops, which are going to give you superhero eyes. And to a child who's well enough, between the ages of 3 and probably about 10, no one can resist having superhero eyes for a little while. It's quite tempting. And I also sort of sell it on the fact that, you know, if they've already had the dilating drops, these ones are genuinely not as stingy as that. They've done the worst ones already. So it's really good to kind of get them on board and motivated. And sometimes I say, maybe mummy could take a photo when the blue light's on, so they can see themselves with glow in the dark eyes. And then you get their chin on the slit lamp and they have a really good look whilst they're interested. Turn it into a game. So we've got loads of great kit, you know, but if you can't get near a child with it, it's no good to you. So for example, in children who are having recurrent steroids because they've got ocular surface inflammation, I will be wanting to check the pressure, and we need to be able to get near them with this. So that's an eye care. Lots of you will know what it is. It checks the intraocular pressure painlessly, but the child doesn't know that, and it has to come really close. So it has this little green light when you turn it on. Well, it goes green initially and then goes red. So I say, this is the red and green light game. And what we need to do, you and I think we can do it. Shall we make it go green? And when you're holding at any angle that isn't where the eye care wants to be, it's red. And I say, the way we're going to do it is if we can get it really close to your eye, I think it's going to go green. Shall we try? And you know, they're quite tempted. You know, you've thrown down the gauntlet. They want to give it a go. And when they do it, you get near it, you press it. You don't need to get 6 times recurrently for a child. You just need to know whether you're talking 40 or 6. And when they get it, praise. oh my goodness, you are so good at this. Should we give your other eye a go? Does it want to have a turn? So, you know, really try and engage them. It takes a lot of energy, but it does pay off. Turn it into a competition. Can you get your chin on that slit lamp? You know, on my special big boy machine. This is, most 5-year-olds can't do it. Do you think you can? You know, that kind of approach. That works if a child is okay. If they are deeply uncomfortable, if they can't get their eye open, if they're in a lot of pain, you know, none of this is going to work. They're not silly. But you can get a lot more out of a child if you really work to engage with them, and it does take practice. I would absolutely consider topical anesthetic early where I think that they are very uncomfortable, and that's a balance because you're going to put in a stingy drop in order to achieve the next things, but particularly if they can't open their eye, we need to consider that. And I would say in general, limit the exam. Don't do things that are unnecessary, but you do need to do what needs to be done. So you have to achieve the things that need to be achieved to make the diagnosis and move on to the next set. And do that if it's within your skill set. I think if you are unconfident that you're going to get to that point with the child, don't push them, don't upset them, don't make them afraid of eye care facilities, and call for help, because that's why we're here. So if you find that you can't get anywhere near, do send them to see us. We're not wizards, and sometimes we do need to reach for a general anaesthetic, an examination under anaesthesia if the child won't let you near them and there clearly is a serious issue ongoing. Then we balance that risk and consider doing that if it needs to be done. And so I'll just leave you with one final red flag. If a child is not opening their eye, and you know it's not a game and they're not just putting it on, that is pretty much an emergency. Don't let them go home with their eye shut, because you need to know why. And it can be that there is sort of a foreign body, or there's a sort of a climax of a condition that we don't know about yet. So for me, a child not opening their eye needs to be accelerated up to hospital care, you know, on the day. So I hope that we have gone through those learning goals and got a bit of more of a working understanding of BKC and VKC. So I will leave it there, but I think
Thank you very much, Naomi.
We've run over a little bit. I do apologise, and I really thank everybody for their attention.
Start a couple of minutes late, so I think you were perfectly on time in the end. Thank you very much. That was a fascinating talk, and I certainly learned some things there, as I'm sure did our delegates. I'm going to fire the remaining questions at you. So first of all, one going back to AKC. Is AKC an adolescent version of VKC?
Yes, to an extent. I mean, there is a family of atopic ocular surface inflammation, and VKC is more found in a pediatric age group. AKC tends to have an onset later in life, and it's largely that distinguishes them. You'll notice that, you know, inflammatory and allergic eye disease have common themes in their treatment, you know, antihistamines, steroids, and to some extent maybe it's a little bit academic, but AKC might be more associated with eczema, periocular eczema. Yeah, so it's demographically distinct, though. You don't commonly see it in children.
And can you treat corneal scarring with steroids?
You can try. No, essentially, if a scar is fully formed, really it's not going to go away with steroid. When I say you can try, is if you think there's any chance it's still evolving, and there's any active inflammation still going, then it is on balance worth trying sometimes. But a really long established scar won't respond to steroids, because there's no active inflammation there. What the steroid is doing is acting on inflammation, and a scar is there's nothing active to improve on, so it won't budge.
And this is also quite an interesting question, actually. When are chalasia treated with steroid injections versus incision and curettage?
Yeah, that's a really good question. I think with chalasia, it's you know, they are unsightly, they are uncomfortable. People don't like them, and it's quite understandable. When would you treat them with steroids versus curettage? Well, steroids topically. So you might be more likely to try steroids topically in a child, particularly if there is sort of active looking inflammation. So it's one of those, if it's red and a bit angry, not cellulitic, but it's active, then steroids can help calm it down. You do occasionally get into that chronic stage where it just looks like skin, but there's a big lump in the skin. And steroids are very unlikely to do a great deal to those. And really, once they're sort of established and they've been there sort of 6, 9, 12 months, really what's going to get them to go away promptly is to open them and evacuate the contents. So yeah, if it's early on and active, I might try steroid ointment. I might try that, particularly if there's multiple chalasia in a child. An ointment, you know, in the nighttime or when they're already asleep can sometimes be helpful. But again, bearing in mind the side effects. So chalasia is a recurrent condition. You do not want to be giving loads of steroids recurrently to anybody, really. So you need to go back to the basic lid hygiene measures. They can be really good. You also don't want to be recurrently incising the eyelids, because, you know, when a chalazion goes away on its own, under the microscope, you can't tell that it was ever there, really. It heals beautifully. Whereas if we go in on the inside of the lid and incise, it does leave a scar. And, you know, that's okay once a couple of times, but you don't want to be doing it recurrently over life, because eventually, with a lot of scarring, you could give yourself an entropion or an ectropion or lid issues. So all of that needs to be sort of borne in mind.
Great. And okay, so next one, is it okay to leave patients with GPC still present if after a dose of steroids they're comfortable and the eye is wide? Is a level of GPC okay to still remain, or do you have to continue with treatment until they all disappear?
And yeah, getting them to completely go away is not always a realistic goal. So if you get it to the point where they're much calmer, because there are structural changes that give you GPC, and it might not be that they completely melt, but what you do want to do is get to a point where the whole disease process is a lot less active, and everything's much calmer. So yeah, you wouldn't, again, it's a balance of risk. You don't want to keep pumping steroids in just to make it look better, if it actually is, it is all doing better, because you've got to remember it's a chronic condition. You're not actually aiming to cure it a lot of the time. You're getting it better controlled, but obviously hoping that they eventually grow out of it and it does all settle down.
Okay, great. And then someone just checking the dosage of azithromycin tablets and drops.
Yeah, so azithromycin drops, the dosage, it's 15 milligrams per gram is the dosage. It's, I think the trade name that's licensed, I think there only is one, and it's called Azita. So there are different published regimes for this, and they can be really complex. Some of the published studies on azithromycin drops for BKC gave patients really complex regimes to follow, and that in my experience is a route to non-compliance. If you do something that's just too complicated, they won't do it, or they'll forget. It's just human. So the regime that I tend to give is 3 days a week. So for example, Monday, Wednesday, Friday, twice a day. So they've had twice a day, 3 times in a week. And then they can have 1 or 2 weeks off, but then repeat it. So 3 days a week, twice a day. So already that's a little bit complicated. I do tend to spend quite a lot of time explaining it. You don't, but it's the upside of it is that actually there's a lot of not doing drops involved in that regime. So I tend to suggest setting a reminder, and you can repeat that multiple times, 3 courses or 4 courses. Some children stay on it. Some children stay on oral erythromycin quite long term to keep their BKC under control. Always with that principle of as little as possible to do what needs to be done.
Great. And can you use aminoglycosides for chalazion?
Yeah, you can. Well, sorry, aminoglycosides. I would probably normally reach for either a steroid, and for example, steroid and neomycin like Maxitrol. That's partly because it is in a combined formulation. So in different countries, you might see different regimes, but it's handy to give because it's all in one dose. Otherwise, I would reach for macrolides in children, erythromycin or azithromycin.
Great. There's another question saying, do you use artificial tears? And I think the answer to that from all of us is yes. I don't know if you have any comments about preferences.
That's a brilliant question. Yes, in all of this, we've not talked about lubricant drops. And that is quite an intentional omission, actually. And they have a role in any of these conditions, in all ocular surface conditions. They're helpful. The thing is with lubricant drops, in an adult, you can say, keep it in your pocket, pop a drop in multiple times a day, as much as you like. What an lubricant drop will do is maybe sort of dilute the inflammatory mediators on the ocular surface, palliate with a bit of moisture that lasts as long as the drop lasts. The issue is, in a pediatric population, generally speaking, if a child is in a position where they need palliation of their ocular surface, they need relief from lubricants. For me, it's more important to treat the underlying cause using the antibiotic drops or steroid drops or immune modulators. And I would do that in preference to using a lubricant drop, because the lubricant drop isn't actually doing much to modify the disease. It's not really doing anything to modify the disease. And again, it goes back to that. If I've asked them to use opatanol and some steroids and some cyclosporin, we could be up to 8-10 drops already. And if I say add in hourly lubricants, it can just bring family life to a stop, I think. So if we're going to drop anything, drop the lubricants. But for children with very mild symptoms and very mild blepharitis, they absolutely can have it. There's no problem with having it. It's just more compliance starts to wane when we ask people to do too much, and the lubricant is the one that goes because it's not really doing anything for the disease process.
Okay, great. So then somebody has a clinical question. They said they had a patient yesterday with a poor red reflex, instilled NAFL, and there was diffuse SPK, but visual acuity they couldn't get better than 620, and refraction was -3 with a one diopter cell. Would you expect once the cornea is healthy that the refraction would change and the vision could improve?
It's an interesting question, and it slightly depends on various things. So it's a little bit difficult to comment on that precise thing. I think that your question is, everything else considered, can we blame 620 vision on punctate staining? Probably not. And of course, I want to know what the refraction is in both eyes. Is this a child who could have amblyopia as well? You may well find the vision improves if that punctate staining gets better, that the vision improves. Whether it would improve from 620 all the way up, I don't know. But it's not impossible, because testing the vision in a child who's really uncomfortable, you're not going to get the best out of them. But with that level of vision, I would be considering all the other things that you would normally consider with reduced vision as well, not necessarily just pinning it on the punctate staining.
Great. And then can steroid injections be used for chalazion? I think we already answered
Oh,
that.
yes, sorry, that's the part of the question I didn't answer, sorry. They can. They can be used in conjunction with incision and curettage, but steroids, they're great, but they do have side effects. And one of the major side effects that steroids can have is depigmentation of the skin. So particularly for anybody with not very pale skin, you may find to get rid of the chalazion and give them a patch of pale skin. That is putting a bolus of steroid near the eye, so you've got to bear in mind the risk to the eye and consider monitoring that. But it is a treatment modality, and as with all things, we sort of look at the bigger picture.
Right. And then what do you tell parents who struggle to get the child to do warm compresses?
Yeah, I mean, sometimes I find myself saying it, and I can hear it sounds ridiculous because the child is currently doing laps around the room and climbing on the furniture, and the thought of them sitting still with a mask on just seems ridiculous. I do say, if they're very little ones, you sometimes get babies and toddlers with chalazion. Sometimes when they're having milk or something, or they're having a cuddle, they might tolerate a little bit of a warm compress. Sometimes when they're in the bath, just doing a little bit of warmth and cleaning the eyelids, it's unlikely to be completely effective, but may help. But as children get older, they do sometimes tolerate it. But again, you've got to be really realistic with your, the patient that's in front of you. Asking parents to do something that's just not possible is sometimes it's just not possible. So, you scratch that and move on to the next thing and wait till they are able to do it, which does happen eventually.
And
well, it doesn't happen eventually for everybody, actually. Some children have developmental delays, autism, think they don't want things near their face. It doesn't necessarily happen for everybody. So, but that's why you've always got to be treating the child in front of you.
And then, yeah, this is one. Why do all contact lens wearers have GPC? All of them with daily, monthly lenses owing to dry.
Yeah, they do. They do. Yeah, and they're generally adults, aren't they? That's kind of mechanical irritation of the tarsal conjunctiva from having a foreign body there all the time, and they tolerate that very well. But that's a sort of a different mechanism. It's more of a mechanical irritation than an inflammatory brewing reason for the hyperplasia. But yeah, I think if you irritate your conjunctiva enough, it can remodel.
Okay, only a few left, so I'm glad this is generating a lot of discussion. There must be a lot of interest. So can a CLL chronic limbal cell deficiency be treated with steroids?
Oh, well, there you are slightly moving out of my area of expertise. You don't tend to see chronic limbal stem cell deficiency in children unless, of course, they've had some sort of trauma to the ocular surface, like a chemical injury. So I think it's I probably would redirect that question to an adult corneal surgeon, I'm afraid. They quite possibly do use some steroids, but it's not in my daily practice.
Okay, and would you recommend the spray-on lubricants for children?
Those, yeah, they don't make a great deal of sense to me, because if you want something in the eye, I sort of think put them in the eye. But and I don't think we can sometimes prescribe them, but some people swear by them. So, lubricants, they come in all forms and thicknesses and ways of dispensing them. And I do tend to say to people, particularly where they're getting them over the counter, that whatever works for them, if they feel like that's comfortable and suits them, then I don't think there's any harm in it. But for me, if I want a lubricant drop in the eye, I would probably just encourage people to put it in the eye.
Great. And then I think the final question of the night, and I think you already answered a very similar one, but what is the oral dosage of azithromycin, and do you pulse treat as well?
So orally, I would switch to erythromycin in children. The dose is erythromycin. If you're giving it for infection, is a QDS 4 times a day dose. And so in children, I give the age appropriate dose by the BNF dosing, because it varies, I think, by age rather than weight, as the appropriate dose for their age. But I give it BD rather than QDS, so twice a day rather than 4 times a day for a prolonged period. And I do sometimes get asked by a pharmacist why I'm doing that, and there is published, there are published trials and evidence to back up why we do it. And it can be really effective, particularly in those really recurrent chalasia, etc. It can be very effective.
Great. Well, I think that wraps up the night. Thank you very much to all the participants for coming. Thank you, Naomi, once again. You've done an excellent job today, and it's generated so much discussion. So it's clearly a brilliant topic. Lots of positive comments coming in, so we'll pass all those across to you, Naomi. Can I just make sure everyone's aware you will get your CPD points afterwards? Do fill in our feedback forms. If you have any issues, get in touch with us, and we'll make sure you get the points. Thank you very much, everyone.